Hello, everyone. Okay, now on to John. We're very excited to have John. I think most of you know who he is. He's a retired physician who practiced in Vermont and served on the faculty of the UVM College of Medicine for over 40 years. He serves as the first CEO of the UVM Health Network and retired from that in December of 2022, that right during the pandemic. So please give a warm welcome to Dr. John Brumsted.
Can you hear me? Oh, good. Well, thank you for that wonderful introduction, and happy Valentine's Day from me as well. I usually start talking like this by letting you know if I have any conflicts of interest. And as you heard, I'm blissfully retired over the last 2.5 years, and I did make it through the pandemic. We got out the other side by 22, but the ramifications are still happening. So I'm retired. I have absolutely no financial or operational attachments to my former employer. I am a professor emeritus at the College of Medicine, and I'm on the board of a not-for-profit health system, the Mohawk Valley Health System, in central New York, and that doesn't overlap at all with Vermont or even where the UVM Health Network is in northern New York. But I do that because of a lifelong passion to make sure that people, particularly in rural environments, don't get shortchanged and that we have access to the absolute best health care that we can. So let's jump right into this. And if I said to you all right here, why are eggs so expensive today? Everybody would say either bird flu or avian flu. And so crisp answer, we know what the cause is. It's looking a little more troublesome than you would think to eradicate that virus and get our egg prices back down. But that's crisp. Why is healthcare so expensive? I apologize right up front. I'm not going to be anywhere near that crisp. I hope that I don't confuse you. I really hope that I don't frustrate you. I hope by the end that you're enlightened by some of the numbers that I'm going to show and some of the information, and that at the bottom line, that you're better consumers of the information that's out there. Don't hit ChatGPT and ask this question, because you will get everybody's opinion that ever wrote anything, particularly in the state of Vermont or New England, and it just gets even more confusing. So I'm going to be really specific as I go through about what I'm talking about. Which healthcare information, which location, which database that I've used, and I am kind of a data wonk, but I'll try and keep it as crisp as I can. We need to be very specific when talking about healthcare, what the question is that we're asking. I'm going to define the terms that we use, and mostly it's the 5 that are listed there. And I am going to focus on healthcare expense and costs in Vermont, but you can't give that talk without doing comparisons either to New England or to the greater US. I'm going to try and deconstruct both hospital costs and commercial healthcare premiums to the extent possible, and what the drivers are of those costs. And then I'll throw out some potential solutions, and this is where it can get really frustrating. If you don't have a crisp answer to why, then what you're going to do about it gets really, really complex. And this situation, despite what you might read, did not occur as a result of the past couple of years or the pandemic. We have moved in the direction that we find ourselves, at least over the decade of the 90s and on, where I've been involved in sort of some of the administrative aspects and the regulatory aspects of healthcare in Vermont. So we've been putting ourselves in this position for a long time, so we're not going to get out of it with a quick, simple solution. So let's do some defining. Total cost of care is the cost of all medical services provided to a population or individual. And remember that the cost isn't the same as the price. It's not what you pay for that doctor visit. The cost is that price of the doctor visit by your utilization of the doctor, how many times you went. Same thing with the hospital, and that gets confused all the time. The total cost is the price of what you buy and the utilization, the volume of the service that you consume. And total cost of care, at least the way we're using it today, really is all-encompassing. Hospital, doctor, pharmaceuticals, whether it's at your doctor's office or the drugstore, skilled nursing facilities, home health, the chiropractor, the dentist. So when we talk about total cost of care in the databases that I'm using, you're really putting everything together. Hospital cost, you'd think, is self-explanatory, and it is the cost of services provided to a population or individual, but it's what's billed by the hospital. And today, there's a lot of things that are billed by hospitals that you wouldn't think are just the hospital. A lot of physicians are employed by hospitals. A lot of the pharmaceuticals that are delivered because of some of the federal programs are billed by hospitals. So you need to be pretty understanding of what's actually included. Physician and provider costs are pretty self-explanatory. Pharmacy costs include the drugs that are used, but also non-durable medical goods. So when you look at the total cost of pharmacy, it includes all of those things that are used in the episode of care that are just used and then either thrown away or consumed. An insurance premium, amount paid by an insurance company for coverage, usually expressed as monthly cost. And more recently, since the Affordable Care Act, most of the benchmarking is based on, if you're comparing one region to another, one state to another, they look at the silver plan, which is one of the tiers in the, on the exchange. So I'll try and be clear on this as we go through. Can't do a cost or a talk like this, like I said, without some national comparison. So this is healthcare expenditures in the U.S. as a percent of the gross domestic product from the 70s to 2020. And you can see that that green line is just going towards the roof, and we're almost up to 20% of the GDP being consumed by healthcare expenditures. And one aside, economists, if there's any economists here, you probably argue with me, but when you talk about in these databases, the expenditures, the healthcare expenditures, I'm equating that to the healthcare cost. And there's little difference, but not important for this conversation. And you can see that the comparative countries that are mostly European, that are in that blue line, are growing, but at a much slower pace, and that they haven't consumed anywhere near a fifth of their gross domestic product. And how about healthcare expenditures in Vermont? This time frame's a little bit different. It's 97 to 2017, but it makes the same point. And this is what we spend our money on in Vermont as a percent of our total income. And that blue line are state and local taxes. And you can see that over time, that's pretty consistent as a percent of our pocketbook. And, you know, that's obviously taxes go up, but as a percent of what we earn, it stays pretty flat. Healthcare, since way back when in Vermont, has been eating more and more and more of our income. Obviously, that becomes unsustainable. And I would argue that we've crossed that line over the past 24 months, maybe a little longer. So I want to tell you just a little bit about this database. U.S. Census Bureau Center for Medicare and Medicaid Services, Office of the Actuary. Every 5 years, the Office of the Actuary, at least up until now, refreshes this database. And this is as close to the source of all-encompassing as I can get. I didn't make the point before, but I'll make it now, that when you're looking at costs or looking at revenue in healthcare, and you're trying to get some sense so that you can compare either relative to somebody else or actually compare different places, you really need to look at the per capita. You need to break it down per person. Why does New York State spend so much more on hospitals than Rhode Island? There's 10 times as many people. So unless you actually get down to the per person level, you can make some really crazy assumptions and some decisions. So here's the database, and this is the all payer, Medicare, Medicaid, commercial, private pay, all payer costs for healthcare. And I've taken New England because that's where we're at. So cost per capita in New England in 2020 in this database was $12,728 on healthcare for every single individual. Nationally, that number in 2020 was $10,191. So in New England, we're more expensive, but these are big numbers. I've listed the New England states. Massachusetts in 2020 actually was more expensive for all-in total health care costs. Remember, everything. Your physical therapist, skilled nursing, home health, dentist, doctor, hospital, pharmacy. In Vermont, that's a hefty number. That's per capita, per individual in 2020, what we spent on health care. And that's been growing over this entire 91 to 2020 at 6%. Nationally, that growth rate is 4.7%. And so we're growing fast. We're expensive, and we're getting more expensive. And for total cost in the country, we're either 5th or 6th. So this is the baseline for total cost. There's a huge kerfluffle, obviously, in Vermont right now around hospital costs. And remember, the cost is the price times the utilization of services. To a certain extent, we can ascribe some of this high cost to we're an older population, and I'll get to that a little bit later when we're talking about insurance premiums. But the rest of New England is aging at the same rate. So we really do have high price. High price utilization driven by a demographic, an aging population. And the trend is significant. We're the highest in New England, $5,638 per individual in our state. And nationally, the number, same year, is 3,800, and I think it's 80 something, but it's 3,800. So we're significantly higher, and the trend rate nationally is that same, I think it's 4.6%. So South Dakota and West Virginia are the only two states that spend more per capita on hospital costs. Now, if you're going to look for areas to target your interventions to change something, you want to know, the old bank robber thing, why you rob banks, it's because that's where the money is. You want to go to where you're going to have the maximum impact. And so if you combine in that same database, all payer, you look at what we spend on hospitals, the hospital cost, and I combined, because we have so many physicians and advanced practice providers that are part of the hospital billing system, I've combined hospital plus providers on this slide, just to see if we're totally out of whack with the percentage of our healthcare spend that we're putting into the hospital. And we're not. We're sort of right in the mix with, I have New Hampshire, Maryland, just because they've done a lot of work with hospital costs. And for New England, it's 60%. So we're about the same. I can't explain why Vermont's pharmacy costs are less. I'm almost certain that's a data collection issue. Maybe it's because we bill those through the hospital so much. But I can't really explain that. But I don't think we use fewer drugs or fewer disposable items in our health care than others. I think that's probably wrapped into hospital outpatient costs. So I've nibbled around this a little bit, but what are the driving factors for our high hospital costs? And I'm not rationalizing, I'm not making excuses. They are high, both price and actually utilization is right in with other states with similar demographics as far as aging. You know, New Hampshire and Maine are very similar. But we do have high utilization relative to the rest of the country because of our demographics. And that's compounded by high price of services. And I have some comments as we go along on how we got there. It didn't happen overnight. Now, this next bullet, I could be the chair of a board of education. I really don't want to do that job, but I could be, and saying the same thing. You know, we have all these supervisory unions, we have all the fixed overhead of all the schools, we have, you know, fewer students, and, you know, we have all of these administrative costs, and how are we going to bring all this together? That's going really well, isn't it? And, you know, we have 14 hospitals for 635,000 wonderful people. And that is a ratio that's really difficult to work, particularly since most of those hospitals, and I would argue even the UVM Medical Center, are in rural communities. Now, I get this information stream that comes from something called Becker's, and mostly they focus on hospital information. And Monday, one came through that there are 430 some odd rural hospitals in the United States that are at significant danger of closing, of folding. Over 400. A recent report in Vermont that I'll get to in a minute, that at least 4, and I would argue almost all, of our hospitals financially are teetering. And it's really a difficult business model when you combine small rural community, small numbers of services, I mean per service, not small number of services globally, but you know, if you only do 20 joint replacements a year, each one of those is going to cost more than if you had it done at a place that does 500 of those a year. So all of those things add in and drive the overall hospital costs, the prices and the cost, to support those 14 hospitals, just like we support all of those supervisory unions, and our property taxes went a little bit crazy. Another thing is a physician who worked as a physician, not just an administrator during those 40 years, the fragmentation and lack of systemized care coordination. There's a lot of friction in the system. If you need to change sites of service, if you need to go from one hospital to another, if you need to be referred to a specialist, without those organizations or providers being in the same network with the same information system, you generate a lot of cost. Redoing things, phone calls, delays. So that's an issue because other than the UVM Health Network, all of those other hospitals are independent. We have an overdependence on hospital services. And this was brought up again in a report that I'm going to highlight for you in a couple of minutes. Because we have a lack of skilled nursing facility beds, we have a lack of home health access in plenty of parts of the state. We have designated agencies and mental health agencies that are understaffed and overwhelmed. If you go to any hospital in Vermont today, you're going to have a large percentage, too large a percentage of the beds that are occupied by somebody who doesn't really need the care of the hospital, but needs to move on to another site of service and can't get there from here. And that just generates cost. Obviously, the nurses take care of those patients, they get their meals, and reimbursement stops after a certain amount of time. Go to any emergency room in the state of Vermont, and many of the beds are taken up with individuals that have critical mental health needs because they can't get to another site of care. So we have an overdependence on keeping people in the hospital because that's the only nidus of services that we have in many of our communities. And then everybody that runs a business anywhere in Vermont knows that this is a wonderful place to be. But not everybody in the universe knows that or believes that. We are a very difficult place to recruit people to, particularly when you recruit a physician who is really raring to go, wants to be here, is leaving Houston, Texas, and their 5-bedroom house that costs $475,000, and they show up here, okay? And that is not just hyperbole. That happens a lot across the board. We have a highly organized labor force now, and all you have to do is look at again, I'm not being pejorative here, but just look at what we've done to be able to support our nurses, our technicians with those salary increases so they can live in Vermont. We all know that housing is expensive. And during COVID, we really had an issue needing to bring in temporary labor. So I've bumped into this along the way. The legislature, seeing this coming a few years ago, I forget exactly when, maybe Jen or Jessica could tell me, but Act 167 was passed by the legislature, and it was to investigate the sustainability of our healthcare delivery system. And the final report of that you can find on the Green Mountain Care Board website. It's Act 167 report. And the final report was given just this past October 24. And right up front, I agree with most of the recommendations and the findings of the report. The firm that did this was Oliver Wyman, had a physician lead. They made a big mistake in that they were a little bit loose with some of their data accrual and data analysis. And the last thing you want to do if you're going to put out a controversial report, and I can attest to this too, is leave any gap so that somebody can question the data. So unfortunately, I think the impact of this might be minimized because they did leave themselves open to criticism of some of the data. And this is a slide that I took right from that report. I reference it down below. Current healthcare costs are becoming less affordable. Premiums and hospital charges outpace median household income. So on your left is 2018 to 2022. It's the median household income in Vermont, and over that time course, it grew 22%. First data problem, the other two slides are over 6 years and go through FY24. So you really, to that 22%, would have to add a couple of years of income growth. And that's, I just point that out as they made several of those. It doesn't in any way dampen that the healthcare costs are growing more quickly than our income. I showed you that slide before. But, you know, anyways. So what I want to point out is from the middle one, from 2018 through 2024, you can see these are what the regulator, over this time course, the Green Mountain Care Board, allowed hospitals, so the whole hospital system, one had a little bit more than another, but the whole hospital system, what they allowed their prices to increase. Okay, and so you can see 2.0, 2.9, and then there's some that are bigger. That 10 that's second to last is when that 22 inflation hit and everything just went right through the roof. That hit a year later and they allowed 10%. But over that whole course, the hospital prices increased 38% over those 6 years. Go to the right, and this is difficult to explain, but if what you consider the cost of healthcare, which many do, it's my premium. It's what comes out of my pocket if I am insured commercially. It's what comes out of my pocket to pay my premium. And that gets conflated all the time, and that's dangerous because that premium, in this instance, the silver marketplace premium in Vermont is that blue line, and it's grown 108%, while hospital charges have grown 38%, and our incomes have grown, call it 27 or 28%. Black line on the far right is the US, and it stayed essentially flat for that silver premium. So what is going on here? Well, one of the things is, you know, price, that 38% is price, the total cost is price times cost. So if you had more utilization, then the cost would be going like this, even though the price was just going like that. So maybe that's what's driving the premium. But I looked at that, and what I did was I took that same database that ends in 2020. I took that 6.7% growth and escalated it forward so that I have the same time course now, the 6 years, 2018 to 24. And our hospital costs, the utilization plus those incremental prices, grew at 41%. So 38%, 41%, that's pretty much you're getting out of the hospitals as far as cost what the regulators decided to do with those charge increases. So this is marketplace premiums 2018 to 25, and this is the same average lowest cost silver. And this comes from the Kaiser Family Foundation. Kaiser Family Foundation, if you go to their website, they've got a lot of neat interactive tools that you can use. You can put different questions in different states, so that's a fun place to go. And the data that they use is that Office of the Actuary data that I've been using all along here. So that's their source data. Vermont obviously is the top purple line, and you can see that we're chugging along 2021, 22. We're expensive, but we're sort of staying at the same slope as everybody else. So 2022 onwards, it just takes off. And you can see that Massachusetts is one of those green lines down towards the bottom. Massachusetts, on the total cost of healthcare, was more expensive even than Vermont. And just as a matter of comparison, their hospital costs, when you pull that out over this time frame, remember Vermont, we've grown 41%, they grew 36%. So something still isn't matching up with the cost of those commercial premiums and either our utilization or our hospital costs. I'll take a step back and I'll just reiterate, our hospital costs are too high. The prices are too high. I'd argue that, our utilization could be a little bit better, but not dramatically. But there is a discordance between the growth of our hospital costs and our premium costs. And I just say that because if you don't get anything from this talk, take away a little skepticism when you hear these bold statements that the premium costs are totally because of this, or totally because of that. It's complicated. It's certainly a factor that our hospitals are expensive, but it certainly doesn't explain that growth there. So is there anything that we can do to look at that a little bit closer? Well, I had to include this just because the numbers are pretty outrageous. That in Vermont, for that lowest cost silver plan, it's $1,275. I know that Jessica and my stepson is having a lot of problems with his small LLC trying to buy those, pay those insurance premiums. So what's driving some of this? I can't explain all of that discordance. I'm not an actuary, I'm not an insurance guy. I can't explain all of it. But we all know that insurance has a business model that you assess the risk of something happening to somebody you're going to sell that insurance to. And then you look at as many different people that you can, or places or businesses you can sell that insurance to, so that you can spread that risk all over. And the bigger you can, population or whatever you can spread that risk over, the more consistent that premium's going to be and the less variation. Same thing's true if you have a really, really small population that you're trying to spread that risk over. It's going to bounce up and down and all over, and it's going to just cost more because you have to charge what almost the worst case scenario is. So this is Vermont, and this is a complex slide, but I'll just point out a couple numbers. It comes from the Joint Fiscal Office. And if you look at the total insured market, which is individual and small group, which in Vermont is a small group, so they're lumped together, and large group, those are large organizations, most of whom buy their insurance from big companies because the others have become self-insured, that's dramatically decreased. In 2025, those premiums commercial premiums on the exchange were spread over 30,000 Vermonters, and the total number of Vermonters in the individual and small group pool was 69,000. Excellus Blue Cross Blue Shield, which serves northern New York and central New York, has just shy of 2 million people that they spread that risk over. And United Healthcare, last time I checked, I think had 45 million beneficiaries that they spread the risk over. Now, not all of that was commercial, but a big chunk of it was. So we have a problem with the small number of people that are getting that insurance. And I'll just put up one slide to remind us how old we are. This is a population pyramid that's supposed to be a pyramid. You can see it's supposed to sort of go like this if you're describing a healthy population, like a pyramid. And we have sort of a midlife bulge right there, like we all kind of get. That bulging on both sides are the women on the right, men on the left, between 40 and 65. So we have small population that we're spreading that a fair number of services, but consistent with the age of our population. There's other factors too. If you really want a snoozer, read what the insurance companies put into the Green Mountain Care Board or any regulator as to what their rate case is. They have to put in a chunk of money to fill the reserves if they lost reserves on prior products. A lot of insurance companies the last 24 months have taken a real bath on us that are in Medicare Advantage plans. And it had to do with some of the changes in the reimbursements. So we also, in Vermont, do some good things. Community rating and guaranteed issue essentially mean that you can't, as an insurer, cherry pick. If you're going to provide an insurance product, you can give it to everybody. In the broader world, insurance companies can price for a specific group or subpopulation. They can't do that in Vermont. You can do it on 5 factors: smoking, age, male, female, and I think geography is the other one that you can use. Not so in Vermont. Now this is one that you just have to take my word for it unless you want to go back and research it, but I've been involved in the regulated hospital budget process in Vermont since the mid-90s. And the driving goal of regulating hospital budgets has been to make sure that no hospital goes under. Now, the business model for rural hospitals, I've told you, in America, is not a sustainable model right now. So if what we've done in the face of that business model that doesn't work is we've guaranteed enough revenue and rate increases to keep all 14 of those hospitals solvent, I believe that that really is one of the core issues. And it's, again, not unique. Look at what we've done with our supervisory unions in our schools. It's the same dynamic. Now, those 430 plus rural hospitals that are in danger of going under, some states just let them go under. Some pad their Medicare rates to keep them afloat. New York has 24 hospitals that have 0 days cash on hand, maybe 1 or 2 days cash on hand. And the only reason their doors are open and their lights are on is that the state of New York provides vital access provider payments, VAT payments, tens of millions of dollars. So their hospital costs aren't much, but those dollars come out of the general fund that are generated by taxes. And so if you're going to have rural hospitals and you're going to have a lot of them and you're not going to address what they do, you've created a situation like we have today. And, I'm a doctor, so I have to throw in that we have some inconsistent policies in this state around healthy lifestyles. We crow and complain about healthcare costs, and then we legalize marijuana. We won't tax sugary drinks. Everybody by the 10th grade is hopelessly addicted to nicotine because they like the tutti frutti flavor. And if you want to get a vodka disguised as lemonade, go into any single one of your local grocery stores. Enough. So I'm up here, I get to take the bully pulpit a little bit. So fixing this, and this is where it gets frustrating, everybody in the political arena right now, and I would say some of my colleagues in healthcare delivery, are looking for that silver bullet. Just do this and it'll be fine. It ain't going to happen. It just isn't. We've taken so long to get into this situation, it's going to take a lot to get out of it. And I'm just going to tell you a quick tale of Moses Ludington Hospital. That's Moses Ludington Hospital in the front, and that's the owned nursing home behind it. And this is about 2005 or 6 that this picture was taken. In 1997, on the front page of the Wall Street Journal was Moses Ludington Hospital, the hospital that wouldn't die. And Moses Ludington Hospital, up to that point, had licensed 50 beds. It was staffed for a daily census of 15 or 20. It had a daily census of inpatients between 0 and at most 5. It had an emergency room that was staffed by nurse practitioners and physician's assistants. And there's a federally qualified healthcare center in Ticonderoga, where Moses Ludington is. Hudson Headwaters, wonderful organization. They were off campus. Anytime anybody in the emergency room was too sick for the PAs or nurses to take care of, they'd have to call the primary care office. They may or may not come right away. It was a mess. They, in 2013, fired their CEO. I won't go into the details on the reason. And we got a call because we had just affiliated with several New York hospitals, but one was Elizabethtown Community Hospital, 10 miles or 30 miles north of here. And they said, can you come and help us? So a couple of our really, really smart executives went in there, and it was just a mess. It was worse than anything. And our residents actually here at the medical center used to call it the Death Star because of how complicated, I'll say, the patients were that came there. So we looked at this, and the Department of Health in New York, which regulates hospitals, is dumping $6 to $7 million a year, and thus the Wall Street Journal article, in those VAP funds to keep the lights on in this hospital so that it's staffed 24/7, 365. So what can we do? Smart executives, they hatch this plan, come to me and others, and let's do this. So sell the nursing home to another not-for-profit that can run it better. Redo the emergency room. Get rid of the inpatients. Just get rid of them. And affiliate and actually merge Ticonderoga with Elizabethtown, which is a critical access hospital. So you could have one management team take care of both, and it was close enough in proximity that we could do that. Well, it's a great plan. Took it to the Department of Health, and they said, great plan, tell us what you need, we'll help invest. And we hit the buzzsaw. The local political folks, wonderful woman who's the state senator for that region, and the assemblyman, and the management of the International Paper Company mill that was there, said, you can't take away our hospital. We need our hospital for this, that. They needed it for an emergency room because maybe industrial accidents. And this is difficult to say, but the main reason that they thought they needed to have inpatient beds was, where else would anybody in Ticonderoga go to die if they didn't have the hospital? So we waded in, we worked with the community, we worked with the employers, we worked with everybody. The state of New York over the next 6 years invested around $10 million. We had some money from the New York side. We invested $4 or $5 million in several tranches, and we merged it into Elizabethtown, and that's today. That is the Ticonderoga campus of the Elizabethtown Hospital. Elderwood is the not-for-profit that runs the nursing home. Hudson Headwaters is there on site. The emergency room is staffed by the same ED docs that staff Plattsburgh and that staff here, the academic medical center. Community is ecstatic, and you know you get it right when you have a ribbon cutting and the political folks come and take credit for the whole thing. And it was and I really, I mean, that's Betty Little on the left, and she's a wonderful person, and she was just defending her community. But and then Dan Steck, who's still, he's now the senator from there. He took took Betty's place. But smiles, happy, and but hard work. One hospital, and the first year I had guaranteed to the Elizabethtown Hospital Board that if they lost money doing this, that we would backstop them. They ended up $750,000 to the positive in the first year. So this is the Oliver Wyman report, and you know, I'll pretty much end on this, that system transformation is urgently needed. And this essentially said in their report that you need to change what you're doing in your hospitals. You need to invest in community services in a lot of ways. And I don't think this is just the way I read the report because I'm biased, but they did say that you got to get out of the way of your providers and their communities, and you have to let them do the work, just like we did in Ticonderoga. And that's incredibly hard for people that are regulators or in the insurance business to do. One of my basic tenets is that the only people that can change the way healthcare is delivered are those that are delivering the healthcare. And they can only do that when they're working hand in glove with their patients in their communities. So here it is. Transfer utilization and financial risk and accountability to the providers. Kaiser's been doing that forever. Make sure that your regulatory decision-making is made on per capita costs and utilization and price, and not, you know, hospital costs, all of New York versus all of Rhode Island. Make sure that regulation incents payers to have risk pools that are large enough. Enact regulation that incents use of Vermont providers. Every time one of us gets care outside of the state loses a 6% provider tax that's on that if the care is given in Vermont. And those tax dollars go back in to support the healthcare system. And here's the real hard one. I mean, everything is interconnected. Improve economic factors which enhance in-migration to Vermont. And we all know that that's it. So I'm a dyed-in-the-wool optimist. If you know Vermont geography, and I think I do, this is a sunrise over Mount Mansfield and not a sunset. So I'm optimistic. I took a little bit long, but we've got 11 minutes for questions.
Okay, that does. Before we start, I forgot one of our board members. Oops. Mary Ellen Bridge is handling publicity, and you're going to get to see her on the way out because she's going to be holding the basket. John, this was terrific. Okay, please raise your hands if you have questions.
Hi. Why is our risk pool getting smaller?
Because we're not replenishing it as people age and move into Medicare territory. Yeah, it's you know, we need the same thing. I mean, Jessica and I have, she has 4 children. I have 4 wonderful stepkids. Only one's in Vermont. The other 3 desperately want to come back. You know, how? So that's what's happening to our risk pool. Sure.
Test. Is it working? Is it working?
Yeah.
Okay.
Hold it close to your mouth.
Oh, I'm wondering, the most recent update, I guess, to the main campus really seems to me, I was there 5 years ago, not in it, but helping a friend, and it really seemed way over the top. It seems like you asked the nurses, what do you want? And then you said, okay, we'll give you whatever you want. There was no negotiation. I mean, it really seems like it could have been scaled back some in my eyes, and maybe that's my age. Maybe it's because I worked at the hospital before it was merged with the physicians in Fanny Allen, but that really seemed, and that didn't appear in any of your reasoning.
Well, it did in the high cost of labor, and I made the comment that the organized labor increases have been very significant in the last couple of contracts. I'm not going to get into that. The rationale from the unions for those increases, and in a lot of ways, there's not a whole lot of negotiating power when the alternative are traveling nurses that cost even more. The rationale was the high cost of living, the same argument that we can't afford housing, we can't afford to live close enough to the hospital, on and on and on. But there's no question that on that backdrop of making sure that every hospital has its doors open, that those labor costs are high. Labor costs in a not-for-profit hospital, just pure hospital, if those labor costs get above 59% of your total cost base, it's virtually impossible to have the margin you need to reinvest in services. Sorry to get techie, but most of our hospitals now are in the 64, 65% of total expense basis for labor.
Hi. You keep talking about costs, and recently and in the past, I have noticed executives in insurance and in hospitals retiring with multi-million-dollar bonuses. And that seems like a lot of money to me. I don't know how you feel, but that's a lot.
Well, retirement bonuses, I can attest to, do not happen in Vermont. They're more common in the for-profit insurance industry. There are hospital executives and physicians that, based on certain factors, do have part of their compensation that they get bonuses. I will say that the recent activity is difficult, even for me. I can just tell you that the academic medical center during COVID and during a prior problem that we had financially in 2008, 2009, we actually reduced executive pay. Mine went down. We froze bonuses, and during COVID, we didn't make payments into the on the employer side for retirement, which was all incredibly difficult to do. On the backdrop of all of that, and I'm just telling you, I'm not defending or anything, if you take vice president and above, and all of their compensation and their bonuses and everything, it's less than 1%. Fire all of them, fire every single one, and tomorrow you won't see the difference in healthcare costs. The optics, I totally understand the optics, terrible optics. But if you're really going to fix the problem, don't wave a red flag in front of people by, doing that sort of stuff. But at the same time, if you really want to fix the problem, it's wasted energy to be jumping up and down in not-for-profit healthcare on executive compensation. And even, there's more physicians and there are more nurses, and with the shortage of both of those, just law of supply and demand, the cost for those people, we all need them, we all love ours, is going up. So,
My second question is a little more facetious. I also live in Shelburne, and I buy groceries. Where do you get flavored vodka at the grocery store? I have not.
You want it, huh? No, it's like the Quickie Mart things. I'm sorry, I lost my words. But if you pull into a gas station, my point is that, they camouflage drinks that have significant alcohol in them. And it's like everything else. It's marketed, I think, inappropriately to young people in the wrong place. You grab one when you're getting gas.
I'm wondering how much Medicare and Medicaid reimbursements have changed over the last few years. Has there been a big difference there?
Medicaid in Vermont, I believe, actually is a success story because working with the all-payer model, we actually have all of the hospitals taking capitated payments for Medicaid. And so Medicaid costs and prices have been relatively stable. Medicare slowly increases. One comment on Medicare, since you brought it up, everybody thinks that Medicare reimbursement is the same everywhere. Medicare pays X for getting your hip replaced here. 4 states away, it pays X. Nothing could be further from the truth. Medicare dramatically changes based on all sorts of mostly esoteric factors what they reimburse for services for physicians and hospitals. So if you use Medicare sort of as the denominator for anything, we're charging X% of Medicare, be very wary. Vermont has the lowest globally Medicare rates of any state in the country, the lowest. Every single year, including 2024, Vermont has the lowest per beneficiary cost for Medicare in the United States. And we're not that good on utilization, it's price.
Here's a Zoom question. Maybe it's going to take you half an hour. What is the purpose of the Green Mountain Care Board?
I'm waiting until 3 o'clock. No, it's the regulatory body that we have currently. And, Vermont as a state, we've always regulated healthcare costs. And the way we do that is by regulating hospital budgets. It was Banking, Insurance, Healthcare Administration when I grew up, BISHCA, which was a group of 14 citizens that sat around that we talked to, and they, went in. But again, every single time, their goal, up until very recently, the driving force was, what does this hospital need to stay afloat? Otherwise, you do what New York does, and you pay vital access provider funds to keep the lights on. Or you do what we did in Ticonderoga, which is the real work and the really hard stuff, because you have to engage the community, you have to engage the providers, you have to engage the regulators, you have to engage the politicians. And I'm sorry, there's just too much rancor going down right now for me, and they're not very much having a cup of coffee and figuring out the problems.
One more.
Your per capita, I'm curious, did that include anything with nursing home cost?
The total cost of care does include nursing homes. So that first one where Vermont's 5th or 6th in the country. That does. But the hospital costs or other provider costs do not include the skilled nursing. If you, I mean, that database that you can get to through the Kaiser Family Foundation actually does break that down state by state on a per capita basis, what we actually spend on skilled nursing facilities.
Thank you so much. This is fabulous. So happy Valentine's Day, everyone. A little treat for you. Little is the word.